I'm sorry, dear ESTS members and webinar attendees, I think we have the technical problem. Now we are online. My name is Lieve de Piepere, your ESTS webinar coordinator and moderator for today. I apologize for the call I have today, but I'll try to do the best I can. I guess you all know the formula, which was a broad success last season with one interactive webinar per month. We will start with the lecture, some interactive multiple choice questions in between, and followed by hopefully a good discussion. It is my pleasure today to introduce you to Professor Chang Hyun Kang from the Department of Thoracic and Cardiovascular Surgery at Seoul National University Hospital in Seoul, Korea. Professor Kang is a very active surgeon and scientist involved in many fields of thoracic surgery. He's a board member of different national and international societies and has published about 150 peer-reviewed publications. One of his special interests is the localization, the management, and the follow-up of ground glass opacities. And we are lucky that he was willing to tell us something about that subject at 1 a.m. local time in Korea. Please, Professor Kang, stage is yours.
Thank you for your kind introduction. I'm Chang Hyun Kang in Seoul National University Hospital. And GG and GGO is a very important topic because currently we are operating more and more GGO patients. And currently because of the CT screening program in the country, I think that we'll see more and more patients in the future. So today's topic is about the GGN and including the radiology and genetic features. And although I am just a thoracic surgeon, not a radiologist or molecular biologist, but I want to share my understanding on this field with you audience, and I want to share some of the discussion about this very important topic. And on the first half of my presentation, I'll talk about the radiologic guidelines and the basic features, and the rest of the talk I will explain about the recent molecular biologic advancement in the understanding of the ground glass nodule. And in the rest of my talk, I will add some of the current clinical researches on the limited resection. Okay, let's go on. What is a ground glass opacity? The definition of the ground glass opacity is very clear. According to the Fleischner Society guideline, ground glass opacity is a hazy increased opacity with the preservation of bronchial and vascular margin. As you can see in the chest CT scan, this is ground glass opacity. However, in contrast to solid opacity, you can see clearly a bronchial margin and vascular margin. This is the characteristics of the ground glass opacity. So what is the causes of ground glass opacity? Most common causes is a partial filling of air spaces. This is most commonly caused by the inflammation, for example, pneumonia. And the other next common cause is interstitial thickening. It can be caused by the fluid accumulation, like the interstitial edema. Sometimes the accumulation of cells, some benign or malignant tumors condition, and sometimes the fibrosis, interstitial lung disease can also cause ground glass opacity. And rarely, sometimes it can be caused by increased capillary blood volume and caused by pulmonary venous hypertension in cardiac disease. And all of these can be the causes of the ground glass opacity. But today's talk interest is under this condition in malignant tumors condition. So because all of the diseases can cause ground glass opacity, the etiology of the ground glass opacity is very, very diverse. From edema, hemorrhage, pneumonia, interstitial disease, all of the diseases can cause ground glass opacity. But today's talk is our focus on the malignant tumors presenting as a ground glass opacity. And previously, it was called as a bronchoalveolar carcinoma, and currently we call it AIS or some MIA or invasive adenocarcinoma. So how many ground glass opacity can be detected in general population? It is not known. Nobody knows the exact number, but we can suspect by using the international CT screening trial. In LCAP study performed 10 years ago, the proportion, prevalence of the partly solid nodule was at 2.6% among the CT screen population. In the recent trial, Nelson trial, the proportion of partly solid nodule was 0.8%, and non-solid nodule, the pure ground glass nodule, was 0.9%. So we can expect when we apply the CT screening, around 1 to 2% of the ground glass nodule can be detected. It's a quite a large number considering those patients are general population, although they had a high risk of lung cancer. So those are tumors conditions. It's everybody knows these 4 kinds of tumors condition when he resected the ground glass nodule: AAH, AIS, MIA, invasive adenocarcinoma. So the important thing when we encounter the ground glass nodule the first time is in which situation we can suspect malignancy. The most common finding of the malignancy is the increase in size. The next common one is a new development solid component or increase of the solid component. These 3 findings are most common findings of suspecting the malignancy. But otherwise, increase attenuation or decreasing size with a solid component, new solid component, also may be a pathognomic sign of the malignancy. And when we can see these findings increase, some of the size or solid portion, usually we can do some intervention, for example, surgical resection. But how many patients will have the ground malignancy out of the ground opacity? And according to the old paper and in the surgical series, in the pure ground glass nodule, 18% of malignancy, and partly solid ground glass nodule, 64% was a malignant tumor. And overall malignancy rate was 34% in whole ground glass nodule. It's quite higher than the solid counterpart. However, we always should remember these patients are surgical resected patients. In a whole CT screening population, malignancy rate is just around 1 to 5%. So not so high like this. But if we tried to resect the ground glass nodule, if we have any suspicion for malignancy, the positive rate will be higher. It was already compounded so many papers. So what will be the natural cause of the ground glass nodule? Nobody knows, because the ground glass nodule has a very, very long indolent course during the long time of periods. This is one of the cases of patients who was presented as a pure ground glass nodule. The patient presented as 8 millimeter pure ground glass nodule in this point, and patient received the regular CT scan, but the size of ground glass nodule increased steadily, and the physician recommend operation at this point, but patient refused, do not receive the operation. The tumor increased size continuously, and 5 years later, solid component developed, and solid components also increased, and physician recommend operation again, but patient do not refuse the operation. Then after 10 years later, the tumor metastasized to the supraclavicular lymph nodes. So patients could not receive operation and started to receive systemic chemotherapy. This is one of the typical form of the ground glass opacity and natural cause of the ground glass opacity. So if we review this case retrospectively, we can see many time period which we can intervene, which we can offer the operation and cure the patients, but the patients refuse it, and eventually it becomes very difficult to cure this disease. This is a typical pattern of the ground glass nodule. So, and because of the indolent feature of the ground glass nodule, and the different characteristics of the ground glass nodule. It is the ESTS recommended the different staging system to solid counterpart. According to the ESTS staging system, in the case of the pure ground glass nodule with the size less than 5 millimeter, and it was defined as the benign, the AAH. So it is not necessary to resect or do something. And in the case of the larger GGN without solid component, it can be stages as TIS, still very early stages. In patients who had a solid component less than 5 millimeter, it can be classified as the PT1 MIS. So these two types of the operation, the tumor is very considered as very early stages of adenocarcinoma. And then if the solid component size increase more than 6 millimeter, we can stage it as a T1A or T1B or T1C according to the size of the solid component. This is the basics of the staging of a ground glass nodule. So what we should do, and when we encounter the patient at the first time, when he could find the GGN in patients, what he should do? This is the Flational Society recommendation proposed in 2017. Is maybe a globally accepted recommendation. And there, if the ground glass nodule, the size of the nodule is less than 6 millimeter, usually the guideline do not recommend any follow-up. Usually 5 millimeter, 4 millimeter ground glass nodule, we don't need a follow-up there and check the CT scan anymore. If the nodule size is more than 6, nodule size is 6 or more, 6 millimeter, and check the CT scan, and 6 to 12 months for pure GGN, 3 to 6 months for the partly solid GGN. This is the first recommendation. Then the follow-up CT until 5 years in both of the pure and partly solid CT. This is a baseline follow protocol for the Flational Society recommendation. So what you should remember is the size is 6 millimeter is safeguard, and the period is 5 year. Follow-up is a safe limitation for the follow-up strategy. And the question is whether it is safe or not to, after 5 years, to do not check chest CT anymore. This is a paper published recently, and they collected the patients, 200 patients who was followed more than 5 years because of the ground glass nodule. 280 patients was followed more than 5 years again, and the total follow-up time is 10 years. Then after 10-year follow-up, they could find 13% of the patient shows growth. And among these 27 patients, 3 patients received operation and was confirmed as adenocarcinoma. So overall, 1% of the patient who had a size less than 6 millimeter and followed more than 5 years shows a transformation of malignancy. So we do not know whether 5 years is a definite safe criteria or not, but very small number of patients still have a possibility to show the progression even after 5 years. Well, I don't know whether next future the guideline will be changes or not. Yes, this is my talk about the radiology's basic guidelines, current basic guidelines for ground glass nodule diagnosis, and some kinds of follow-up, and some kinds of indication of intervention. And may I continue?
Okay, for sure.
And next,
have any questions? They can ask the questions in the right sidebar in questions. I don't have seen any questions yet, but yes, if they have questions, they can put them in there.
Yeah, okay. Maybe this is maybe because of very easy area. This is a very easy area to understand. And maybe every audience understand it. This is very, very common and easy one. And the next topic will be about the genetics. Genetics is a difficult and very complicated issue. And I do not understand the whole of the current papers completely, but I want to explain as I understand about the genetics of the ground glass nodule. As you know, recent 10 to 15 years, many researchers could find the drive oncogene in the lung adenocarcinoma. It is a very, very common and very well-known phenomenon. And they could find their KRAS mutation and EGFR mutation, ARC fusion, MET, LOS, HERT, very, very diverse kinds of the mutation profile were found in adenocarcinoma, but still 1/4 of their tumors was drive mutation was not identified. This is a very, very common sense. However, if we will look at the ground glass nodule, we could find some of the difference between the solid counterpart. This is the study, and the earlier phase study, 6 years later before, and they compares to check the target gene mutation and target gene sequencing, and for the EGFR, KRAS, and ARC, 3 genes or mutation was checked, and they could find that AIS, MI, and raphidic type of the tumors. This is the GGN dominant tumors. The EGFR mutation rate was higher, but this is a KRAS mutation. KRAS mutation was very low in this kind of the tumors, especially. But in contrast to the GGN dominant, GGO dominant tumors in solid counterpart, KRAS mutation, especially mucinous adenocarcinomas, KRAS mutation was very high. This is a very well-known phenomenon, so it is a general consensus. It becomes general consensus. EGFR mutation is very common in the ground glass nodule. However, and this paper is comparing the EGFR mutation and their growth potential in the group of GGN. All of the tumors were GGN, which was different from the solid counterpart. And you can see the EGFR mutation rate was 65%, very high. However, if in this patients group, if they divided this patients group into the less invasive and relatively higher invasive group for AIS, MIA, they could find the EGFR mutation represent more aggressive tumor. It's a very contrast to our common sense. You should remember this patient group includes only GGN. In the only ground glass nodule, it's EGFR mutation means poor prognosis. Why is it? Because in a counterpart, AIS, AH is the indolent tumors as a no mutation was more common than the EGFR mutation. We don't know what was the mutation, driver mutation in these patients. However, this study has a really basic, significant essential limitation because they checked only 3 or 4 target genes. We do not know the whole genome sequencing profile. So currently, most of the papers are focusing on the whole exome sequencing. This is a very famous paper published in 2014 in Nature, and they sequenced the whole genome in the adenocarcinoma patients. They could find that the TP53 mutation was the most common mutation as a tumor suppressor gene. The next was the KRAS, EGFR, something. And then, so this finding is a very common phenomenon in the adenocarcinoma. So what happened if we apply the whole exome sequencing in the GGN dominant tumors? This is published this year, and the authors try to compare the solid part to the GGN part. This is a GGN dominant tumors, AIS, MIA, and raphidic pulmonary adenocarcinoma. This is a solid counterpart, SCNR pulmonary adenocarcinoma. As you can see, the yellow color is a pure GGN, brown color is a mixed GGN, and then the black color is a solid tumor. You can see in AIS, MIA, the pure GGN is more dominant. If you look at the mutation profile, EGFR mutation was common here, but strikingly, the TP53 mutation is very rare in the GGN dominant tumors, contrasted to the SNL counterpart. So it is a quite striking difference between the overall whole adenocarcinoma group and the GGN dominant group. TP53 is quite rare in the GGN dominant adenocarcinoma. So why it happens?
Can I just question? Yep. We have one question here. How could we use this kind of information in practice? So the knowledge about the gene mutations in the GGNs, how can we use this in practice?
Yes, I will mention about what will be the role of the mutation study in our practice in the rest part of my talk. And the first, in my opinion, first one is and the benefit for the patients is to apply the adequate the systemic treatments, for example, TKI. And the next one is enrollment patients for the prospective trial for the new agent, which is we have many new agents not yet tested. And the other one is we can predict some kinds of the prognosis in the patients using the gene profile. The rest one is theoretically, and we can predict the malignant potential of the patients, so we can select the type of operation and extent of operation. And that is only the last two parties, the theoretical one. But I think that we can, if we can get more information, more and more, we can apply this genetic mutation or information to the practice of the patients. But currently, around more than 50 to 70% of the patients, the role is just a research basis, and maybe, but however, information produced by research is very important for the future development for the treatment. May I continue? Okay,
sure.
So it's in the tumorigenesis, two different pathways has been suggested. In the GGN dominant tumors, usually EGFR mutation-based tumors, the TP53 inactivation happens. This is a very important gene for the tumorigenesis, but it happens in the later stages of the carcinogenesis. So in the early stages of cancer, we cannot find the TP53. So it is why we cannot detect this gene mutation in EGFR mutant dominant pathway. However, in KRAS, BRAF mutations, and the P53 inactivation happens in a very early stage. So it is why we can detect that this one is very commonly detected in these patients. So it is some kinds of different way, different time interval of the occurrence of a specific there are some kind of mutations. So it is why we can find the difference between these two pathways. So researchers come to understand that these two kind of pathways have differences. The one is for example, KRAS mutation. This one is EGFR mutation. As we know, the KRAS mutation shows a higher mutation burden compared to EGFR mutation. So number of the truncal mutation is very higher compared to EGFR mutation. The accumulation of a mutation happens here in truncal mutation. So many mutation profiles can be identified. And so when we resected the tumor at this point, we can find several mutation profile, and at this point, some of the mutation we found in this branched tumor, and the other cells can show like this one. However, in EGFR mutation and in truncal mutation, common mutation number is very small, and so overall mutation burden is number is very small. This is how the researchers understand the mutation profile of the lung cancer. So. And all of the mutation happens and in different way and different pathway. So that we already know that there is many heterogeneity intratumorally and between tumors. And this is a study comparing intratumoral, intertumoral heterogeneity. And they compare the different tumor mass adenocarcinoma AAH in the one same patients resected 2 tumors and sampled many points in the tumor mass and compared the mutation profile. And they could find the common mutation was found in the KRAS in both of cells, but the type of KRAS was different. So and the terminal branched mutation also different between each location and between tumors. So they can conclude that these 2 tumors are derived from the different cells. So this is how they understand how the tumor mutation can be accumulated. And the other one is the same as the EGFR mutation was common in between adenocarcinoma and AIS. However, the specific mutation type was different. So these 2 tumors come from the separately, but however, branched mutation was the same. But although some of the branched mutation were the same, similar, the truncal mutation was different. Conclude these 2 mutations. These 2 cells come from the different cells, not the same tumors. So according to this theory, all of each tumor cells can be plotted like a gene trees. Here is some of the tumors have the common truncal mutation, and some of the tumors have the branched mutation here. So this is the way the very diverse nature of the lung cancer. So why, as the current systemic treatment is eventually failed because of the diverse mutation profile in each subclones. If we can kill this one, but this one eventually survived and shows resistant to the TKI, some of the target agent. So I think that we should long way to understand what is the future of the mutational study, and to understand the complete the tumor behavior. We need more time, more research, I think. And I must answer to the previous questions. And this is some of the papers presenting what will be the role of the mutation study and what will be the role of the immune checkpoint expression studies. And according to the studies, the medical oncologists assumed that maybe around 20% of the patients will be candidate for the TKI target agent, and maybe around 30% of patients may be candidate for immunotherapy, and other half of the patients we don't have any. So, and the platinum-based conventional chemotherapy may be available for these patients. So when you do check these findings, the medical oncologist can separate the patients group, and they can easily select the proper treatment for the patient's outcome. But especially this is not related to the surgery. However, it is a very important issue to understanding tumor lung cancer and the future therapeutic advancement for the lung cancer, I think. Lastly, I will talk about the surgical treatments, because I'm surgeon. This is a JCOG study pipeline, and then it's a very famous table. And according to the JCOG, Japanese Clinical Oncology Group, and they recommend the surgical method extent according to the size of the tumor and the consolidation to tumor ratio. It's a proportion of solid portion. And in the case of the solid portion less than 25%, they recommend wedge resection, just wedge resection. And between 25 or 50%, they recommend segmentectomy. And more than 50% to 100%, and they are still doing a randomized control trial, segmentectomy versus lobectomy. And they also are doing the phase 3 study for this wide wedge resection and segmentectomy. However, these 2 studies, JCOG 804 and 1211, is a single-arm observation study. So we cannot get the comparative result between the lobectomy something. So just is just an observational study. So and someday we can get some overall outcome, but we don't know whether it is better than lobectomy or not. But this is a JCOG 802 is a randomized control trial, very famous study. We are expecting the outcomes of this study. Very, I think, very important paper it is. And according to the JCOG guideline, and in these patients, whether the tumor is a GGN, GGN, which is around 70% of the solid component, then and whether to do a segmentectomy or lobectomy is now under investigation. JCOG 802 is now undergoing. So in this case, GGN, who has a solid portion around 10%, and in this case, they, according to JCOG recommendation, wedge resection is enough. And these patients can be involved with JCOG 804. So according to the size and the proportion of GG, solid portion, no portion can be changed. But in this advanced GGN, we don't know the answer. Hopefully, maybe Japanese researchers are expecting the equal survival comparing to lobectomy. Unfortunately, this year, the JCOG 802 result was published in JTCVS, and they only reported early result, and the early outcomes of segmentectomy shows a higher intraoperative blood loss and a higher air leakage, high chance of chest tube reinsertion compared to lobectomy. So a little bit poorer result compared to lobectomy. And in the discussion and the result section, the authors provided a comment on it. And the complex segmentectomy was a problem, and it was technically difficult. And the other issue is using the electrocautery or stapler and when dividing the segmental plane. And though the initial result was not better than the lobectomy, I think that the primary goal of the study is not the early technical issue. This technical issue can be overcome when it can do more segmentectomy. That's not the big problem. The primary goal is overall survival. Whether we can get an equal overall survival compared to lobectomy, I think it will be better options for the such GGN patients. So let's go back to the patient, the GGN patients. You can remember the patients with 10 years of history, very slow history, eventually shows a metastasis. And we, considering the patients received randomly CT scan screening in any time point, the patient, so we must expect what kinds of operation can be applied. And according to the JCOG guideline, you can consider wedge resection from this point to this point. It's around a 5-year time interval. And you can apply the segmentectomy from here to here, and lobectomy here from here. And then when we considering the exposure time of each surgical method, we can easily expect what will be the future operation for the GGN. And so maybe 50% will be wedge resection, 30, 20, 40% segmentectomy. Lobectomy will be 10 to 20%. It is my expectation.
Okay, question from the audience. Yes. In the GN and solid, also, do you perform sometimes a biopsy, or do you always go for wedge? Or so the question is, if you have do you make a biopsy before and after the treatment in GGN and solid? So now you're telling us you have a GGN that is small, then you do a wedge. It's larger or more solid, then you go for segmentectomy, and so on. Do you ever perform just a biopsy?
Usually in our center, we don't do biopsy because it is well known in many papers and needle biopsy accuracy rate is quite low. The accuracy rate around 60% for GGN. And when it depends on the size of the solid component, if the solid component size larger, the accuracy increases. But in most of the cases of the small solid components, accuracy is very low. So we just decide whether to resect or wait and see, observe. And that's the two-way in our institute. And the second is neoadjuvant or immunotherapy. And usually in GGN is really most patients have a very present as a very early stages of lung cancer. Usually neoadjuvant treatment is very rarely performed. And then the most advanced type of the GGN is a multifocal GGN, but in the cases we just resect some of the more advanced part and left the other benign features of GGN. So neoadjuvant treatment is quite rare. Immunotherapy can be applied when the patient has a recurrence, a multiple recurrence. Sometimes GGN recurrent in the bilateral lung. Immunotherapy can be applied, but I don't know the actual outcomes of immunotherapy in the ground glass nodule.
Okay. Another question, what about the lymph node sampling in GGNs?
I don't do. But it is controversial. Some surgeons recommend to do sampling, but I never did the sampling or node dissection in case of wedge resection. If I want to do the wedge node dissection, maybe I should have done the segmentectomy, not the wedge resection. Doing the wedge resection means that I will not do the lymph node dissection. It's in my practice. Yes, usually in the papers about the wedge resection on the GGN, they usually didn't do the lymph node dissection.
I agree. The most important ones will be the in1 nodes, so then you can better go for segmentectomy. No.
Sorry.
The most important ones will be the in1 nodes, not the in2 nodes in such a kind of lesions. So then you better go for a segmentectomy instead of that.
Yeah, right. Detail. Yes.
If you want this.
In case I always segmented. Okay. Yes.
Okay.
Usually I don't do the media. The next question is about the invasive mediastinal staging. I usually don't do mediastinal staging in the case of the GGN. And because currently our knowledge base is based on the experience of solid tumors, usually published from the United States and Europe, and 30 or 40 years ago. And at that time, the mediastinal staging was very important because the tumors were very, very aggressive. Most of the tumors from the smoking and the KRAS mutation, something. But currently in the GGN with the EGFR mutation and the lymph node metastasis is not common. It's not common. It's a very, very rarely detected. And in the patients who has a lymph node metastasis, we can expect because of in the cases SUV value is high and compared to size. In the case is solid component is component size very high. So in that such advanced and GGN, we sometimes do invasive staging, for example, EBUS TBNA. But usually in most of the cases, we don't do invasive mediastinal staging. I think it is not necessary anymore in case of GGN.
Okay. Please go on. You had your take-home messages, or did you want to ask the audience some questions? Did you want to ask the audience some multiple choice questions or
to audience?
Yeah. And I think it's time for them to work a little bit now. Huh?
So can they reply to my answer to my questions?
For sure.
Yeah. Okay. I'm not sure. It's because most audience is from the Europe. I don't know what the situation of the Europe, because in the Asia, in our country, the GGN, our surgical practice is more than half of the patients was now being operated because of GGN. And what is the current situation in Europe? I think the situation may be different country by country, and what is how many patients are operated in your country or other countries in Europe. It's the same as our country. More than half of patients is GGN or something.
So for the people who don't find where to answer the questions, in the right sidebar, there's 3 columns. There's questions, polls, and people. The questions you've been asking, that's already very good. And then the second one is polls. There you have 7 multiple choice questions asked by Professor Kang to see what the practice is from the audience. So please try to answer those questions, question 1 to 7, and then he can also comment on that.
Yeah.
In the meanwhile, we have another question. What do you think about SABRE for GGNs?
Yes,
I think that we have pathology.
Yeah, I heard some of the clinical trials now undergoing for the SABRE for GGN, but I'm not sure whether it is a valuable treatment or not, because currently radiologists, therapeutic radiologists think differently from FAST, because recent studies which has and then who received the biopsy, pre-treatment, and then SBRT. And currently we can see many papers which was different from old one, and because all the papers was just to apply the SBRT without any pathology confirmation and shows a very, very good early long-term result. But and the current series is who received the diagnosis correctly, the long-term outcome is not better, not good. And so they can realize the most of the patients, many as the significant part of the old study, patients in the old study was not malignancy, and there's a benign patients were included in that old study. So they can now realize. So the GGN, SBRT for GGN has the same potential risk to radiate the benign lesion. And so I think that it is a good for clinical practice or ethically. I'm not sure. I don't agree with that, because most of the GGN is not a malignancy. So we must wait and see. And if it is suspected, we can resect them, and then we can analyze the mutation profile. What will be the prognosis? Will be of the nodule we can expect then, and then apply the appropriate treatments according to the mutation or some kinds of the situation is better. I think it is my opinion. SBRT maybe sometimes useful, but now currently I don't think it is a possible option.
I agree. Can I ask to the audience to please be very active in answering the questions of the poll, because we only have let's calculate 16 to 17 answers on some questions, and there's many more people out there. So please try to vote on these questions, that we can have a good idea of what the audience practice is, and then Professor Kang can also comment on that. In the meanwhile, if you have any questions yet, then please ask them in the questions bar, being on the radiology, the genetics, or the surgical treatment of GGNs. I see that there's already a bit more people answering, but I think we give it another 2 minutes, and then we can comment on that. Any questions? Yes. What about the multiple foci in the GGNs? So it's not, if it's not one single GGN, but if you have multiple lesions in the same lung in different lobes, what do you do then?
Yes, so I could see the result of poll, and I can see the result of poll quite interesting.
Oh, wait. Maybe we just let the audience a little bit more time to vote. We have two new questions. So what about multiple foci in GGN? So if you have not one lesion GGN, but multiple of them, what do you do then?
It's according to the Fleischner guideline, and the multiple GGN and the practice guideline should follow the most invasive GGN. So if one ground glass nodule is suspect to be a malignancy, and the treatment plan should be determined according to the most advanced one. But however, because multiple GGN has an accumulated risk of each GGN and to be transformed to malignancy, they recommend the initial follow-up CT scan, irrespective of the size, in for multiple GGN. And in the case of the surgical candidate in my practice, and when if we can, my target region is the mixed GGN, the other pure GGNs, several 2 or 3 pure GGNs can exist as around the target regions. I usually resect it and check the malignancy or not. And it is because later secondary operation is sometimes a difficulty, and so is a prophylactic resection. But however, the other GGN location is difficult to resect, or other side, contralateral sides, I just just observe and wait. It's my current practice. However, I think the multiple GGN has a more higher risk than the single GGN to be transformed to malignant region.
Okay. And then what about the location? If you have a deep nodule, just performing a wedge can be very difficult. What is your approach then?
And then just the observation. and
just observation.
And in the deep nodule which is increasing solid, we had a solid component and increasing tendency, I do a segmentectomy or lobectomy and not do a wedge resection. And in the pure GGN, slowly growing, and in the deep nodule, I just wait. And
you wait longer. Okay. What about recurrence in different locations throughout the lungs?
The recurrence rate of GGN is really low. Like GGN usually, our practice is stage 1 GGN is a cure rate around 95, 98%. Its recurrence is very low. Rate is very low sometimes, and the nodal recurrence is very rare. It's mostly presented as a multiple GGN in the bilateral lung. It's a common way. So I think that because of the good prognosis and some of their usually the systemic treatments usually not necessary in most of the cases. Yeah.
Okay. And how do you do your follow-up then? So you have resected your GGN, and then you do a new follow-up, and that's just the same according to the Fleischmann Society recommendations, or do you perform after resection of a GGN? Do you perform a new CT scan every 6 months? What do you do then in follow-up?
Initial stages, when I first meet the patients, I recommended 3 months follow-up for mixed GGN and 6 months for pure GGN. It's earlier part of the follow-up protocol, and usually then after I recommend annual or biannual follow-up. But usually I follows more than 5 years. So as I mentioned, that after 5 years, some GGOs grows. Usually I recommend 10-year follow-up. And after 5 years, I recommend biannual, or 3 or 4 years later, and I recommend the CT scan. So, and then the follow-up is very important, but the compliance rate is not so, I think it's not so high. So some patients do not visit again because after 5 years, I think they are thinking that this is a benign. It's not necessary to receive the CT scan again. So this is very important to give correct information that this is not a benign. The potential malignant transformation is possible. And so usually I follow the Fleischmann guideline, but not exactly same as the Fleischmann guideline. Yeah.
Okay. Then with the knowledge of genetics and the GGN, where it can change the nodal management in the future. That's a question for the future, I think. So we know a lot more of the genetics in the GGN. Will that change our therapy in the future? When you added therapy,
understanding of the genetics I think will changes our management protocol, not only for the nodal management, but also for the overall management scheme. And for example, the EGFR mutation is a hallmark or key factor for the GGN, but we can detect it in the, for example, liquid biopsy, and then detect the EGFR mutation and the tumor with some kinds of GGN feature. And then we can do some of the very, very limited surgery or limited intervention. For example, resection or radio frequency or SBRT, all of the options may be possible. And that is a way to correctly determine the treatment plan. And then we can, if we can find some of the KRAS mutation is preoperatively on some of the poor prognosis mutations, and then we can apply some of the neoadjuvant or more systemic treatment preoperatively or postoperatively. It is a future plan, but we don't know the exact information which mutation profile is valuable for the treatment planning. But currently, we are still undergoing the current research work for the mutation profile. I think that in the future, it can change the overall scheme of a treatment plan, not only for the nodal management, but also for the overall treatment, resection extent, and the indication of the surgery and the overall indications. It's my expectation, but not currently available yet.
Okay. Yes. Okay. Maybe we can look to the polls right now. Some more people have voted. Question 1: what is the proportion of patients with GGN who underwent surgical resection in your practice? I see that more than half of the people say it's less than 10%.
Less than 10%, yes. Okay, I can understand.
How is that in your practice? Yeah. How is that in your practice?
So my practice is around 50%.
50?
Half.
Okay.
And
okay, that's a huge difference.
Yes, I heard that in the Chinese and Japanese major centers of lung cancer, they are operating 70 to 80% of GGN. It's very, very high. And we are not so. Our country is not so high like as China. In China, some centers do around 90% of lung cancer with GGN. So quite different.
Why is that? Because of screening programs?
Yes, screening, yes.
Do you screen in Korea?
As we had a private insurance program for screening, but actually this year we started a national screening program. Yes, we expanded the program, and this year and the government started a national screening program for free and for all the risk populations. So I think this is the first time in the world internationally performing the chest CT screening program. We are expecting the explosion of the GGN in the near future, I think.
Okay. Second question: how long do you follow up with patients with stationary GGNs? So most of them do for 5 years, and I think that's what the Fleischer Society recommendations were asking also.
Yeah, it's correct. Yeah, correct answer.
So this is correct. Yeah. Then question 3: what is the size criteria for resection in case of persistent GGN? There, it's in most of the cases people answer only in case of suspected malignancy, so increase in size or more solid component and so on.
Mm-hmm. It is a little bit controversial. In some centers, and they had their size criteria. Even if the GGN does not increase, if the GGN size is more than 15 or 20 millimeter, they apply the operation. And so some centers use 15, some centers use 25. But our centers previously our center used 15 millimeter. If the GGN size is 15 millimeter, not shrink and it's persistent, we apply the operation. But currently, 1 year ago, we changed it to 25. So I think that because of the indolent nature of GGN, as a size criteria is increasing. And that's according to the Fleischner guideline and the operation only in case of a suspect malignancy is a correct answer.
Okay. Then question number 4, what is your indication of mutation studies in patients who receive an operation? Is that especially in the GGNs? No, sorry. So the question, all adenocarcinoma, only advanced stages, all except GGN, only in case of recurrence or only when systemic treatment is required. Most of them say all adenocarcinoma or even more, only when systemic treatment is required. How do you perform your clinical practice?
Yes, we perform those 3 famous mutations, the EGFR, KRAS, and ALK mutation. We are doing the mutation study in all patients with adenocarcinoma. And
so all 1A and 0.
Yes, it's a answer number 1. It's our hospital's policy. But
does it make a difference for later therapy?
Sorry?
Does it make any difference for later adjuvant therapy or something? If you have it in PT1 in 0 adenocarcinoma, you did the whole mutation studies. What do you do with it?
Yes, we do. We have done it for a long time. maybe around 7 or 8 years ago, we started the program, and in our national insurance system, the national insurance covers the exams P. So we are currently doing all of only 3 mutations. But in case
does it sometimes change the management of your patient or the disease?
Usually not change the management, but in case of the recurrence, patients who had an EGFR mutation, but 2 or 3 later patients had recurrence, we can easily talk to patients. Yes, you have some of the target agent is effective, so do not be disappointed. We have a second option, so we can explain it to the patients. But in most of the cases, patients with the GGN, the recurrence is very, very rare. So most of the studies are useless, but it is very good for the understanding, and we have gathered some information. Yeah.
Okay, I agree. Question 5: what is the list of routine mutation studies in your clinical practice? And there, 42% says EGFR, ALK, and KRAS. So that's most of the answers in there. So quite extensive. What is your comment on that?
According to the NCCN guidelines, and EGFR and ALK mutation should be checked routinely in all adenocarcinoma, and it is NCCN guideline. And then our hospital are doing the same as number 3 is our practice patterns as the most common answers. And however, we have some of the mutation panels, including 150 genes in our hospital. So in case of advanced tumor or rare type or some kinds of neuroendocrine tumor, we apply the more comprehensive mutation studies. And maybe the proportion of the patients around 10%. But however, routine practice is EGFR, ALK, and KRAS in our hospital. Yeah.
Okay. Question 6: how many patients received sublobar resection in your clinical practice? And there the majority says less than 5, although 1 in 4 has in between 5 and 10%. So in your practice, it's much more.
And my practice is around 30 to 40%. Yes, I am very cautious, and because we don't have a result of JCOG 08 or 2 result. So And I just applied a limited resection for the very small size of solid tumors, and sublobar resection is usually can be applied for easy or simple cases. If we can get some of the result of the JCOC study, I think we can do a more segmentectomy or limited resection. Yes.
Okay, and then I like the seventh question. If you are performing the sublobar resection in a small number of patients, what is the most important cause that it is such a small number of patients? The lack of candidates, people say, but almost equally, the lack of evidence for a long-term outcome. And then others say a lack of established guidelines and technical difficulty. Any comments on that?
Yes, because in the question one, on the only small numbers of GGN, and you can see in your clinical practice, maybe a sublobar resection, maybe another major resection for your clinical practice, and then the other, but in the situation quite different in our country. We can see many small GGNs, so we can do a more sublobar resection. But however, the problem is we don't have any evidence for the long-term survival, and we can get there some long-term survival data from the multi-center randomized trials. I think we can expand the limited resection program more widely. So it is why we are waiting for the JCOC result very eagerly. And I think there will have a great impact in the clinical practice of our lung cancer surgery, like the lung cancer study group result as 40 years ago, the JCOC study or other randomized controlled trial, and will change the current practice significantly in the future. But the reason for me, the most important, significant reason why I don't do this limited resection is because we don't have any evidence for long-term outcomes. Maybe most important to it.
Okay. Some additional questions came up. I think one very important one: how do you perform detection of your GGOs during operation? So we found something on the CT scan, but sometimes it's very difficult to find it back during the operation. How do you do that?
What else? The questions? Is
So it's the third question you will see. I think how do you perform detection during the operation?
How you detect? Yes, we use the localization quite extensively. And sometimes do CT guided localization, and sometimes do navigation bronchoscopy localization. So localization is very important. Yes, usually we cannot touch it in the best operation. Yes,
that's why. Yeah. Okay, very good question. What about the risk of having the malignant GGN appearing on other locations that previous one already operated ipsilaterally? That's something I don't really understand.
The incidence of the GGN after operation?
Yeah, I think so.
And our group reported the GGN after the lung cancer surgery as maybe 7 or 8 years ago in thoracic surgery. The incidence is quite low, less than 5%. However, the actual malignancy rate is quite higher than the GGN detected in the normal population. It is well known, though the patients who had a previous cancer, the malignancy rate of GGN is also higher than the normal population. So, but I don't know what the exact rate of the malignant rate. It's maybe presumably it's around 5%. Yeah.
Okay. And then the last question to end with. If you perform any sublobar resection, what is the risk of metastatic disease in 5 years? I think that's a bit depending on what we
yes,
find there.
The retrospective papers from Japan. Usually, Japanese surgeons are pioneers on this issue. Usually, metastatic disease, so it usually means so nodal metastasis is not so common. Usually, the recurrence in the resection, parenchymal resection margin is quite common, and because the intrapulmonary metastasis is problematic in the segmentectomy. But sometimes the nodal metastasis happens. But currently, we can see many papers about the stars. Spread through aerospace is one of the most important reason for the intrapulmonary metastasis. So it is usually can be detected in solid type or micropapillary type. So it is so it will be. I think it will be the future guideline in solid type or micropapillary invasive adenocarcinoma lobectomy is the standards. But however, in case of lapidic and AIS and MIA, usually intrapulmonary metastasis is quite rare, so segmentectomy is relatively safe. And then the overall outcomes comparing the pathologic diagnosis and the recurrence rate of a segmentectomy, we should wait for the randomized controlled trial. And the metastasis risk is not so high, but local recurrence risk is somewhat high in case of solid and metastatic tumors, I think.
Okay. I would say on behalf of the ESTS Learning Affairs Committee, I would like to thank you, Professor Kang, for this very interesting webinar about the radiology, the genetics, and also the surgical management of these GGNs. Thank you to the audience for listening, for being very interactive, and we'll see you within about 1 month. You can follow all these webinars also through our website of the ESTS. So thank you, everybody, and hope to see you next time.
Thank you.
Bye.
Thank you very much.